This kind of gives you an idea of the scope of the problem. Almost 30 million non-cardiac surgeries performed every year. About a third of the deaths that occur post-operatively or perioperatively are related to heart conditions. And, sorry, I'm just going to adjust this a bit. And we spend about $30 billion a year trying to find out who is at risk and how to lower that risk. So as practitioners, our strategy is to approach a patient, say, are you a high-risk patient going into the operation? And are there tests that we should do to try and discern whether or not you are a high-risk patient? And then what kind of interventions can we make to lower that risk? That's our challenge. So our learning objectives today are to review the clinical features that make a person a high-risk patient, to recognize whether the existing data, and there's quite a bit of data out there, support the idea that non-invasive stress testing can actually lead to a strategy that lowers patient risk, and then finally to go over the AHA-ACC recommendations in how to address all of this, because there are now I think some pretty good guidelines on how to address this topic. So, since I gave the talk last year, a paper was published by a group of anesthesiologists, and they asked the question, how well do anesthesiologists follow the ACC-AHA guidelines? So I thought this was an interesting paper, and you can see on the top line, if the patient has an active cardiac condition, so heart failure, arrhythmias, unstable angina, anesthesiologists are pretty good at following the guidelines. But then if you look at all of the other, where there's no active cardiac condition, whether they're going for low-risk surgery, intermediate-risk surgery, high-risk surgery, and whether they have either zero risk factors or a lot of risk factors, not a lot of guidelines being followed. And so what I want to do today is try and create a strategy, go over those guidelines, and then see how well you guys would approach that. So here's an example of a case, a 60-year-old man going for hernia repair, and he's asked for Dr. Feldman to be cleared. And his activity is limited, but he can walk around the house. He has hypertension, hyperlipidemia, type 2 diabetes, so he's got lots of coronary risk factors. Normal exam, normal EKG, he's got some renal insufficiency. And what would you recommend going into surgery as part of his preoperative risk assessment? And we can even do this by hands. Anybody want a dobutamine echo preoperatively? Anybody want a persantine thallium? Proceed to surgery without stress testing, and then proceed to surgery but begin a beta blocker first. So there's a smattering of opinions, and most people wouldn't answer, so it's hard to get a sense of what people would do. I think that as a cardiologist who sees a lot of these patients, I get the sense that a lot of people would want some type of stress test. Whether, at a meeting we act a little differently, I think, than we do in real life. And a lot of times people would say, I want some type of dobutamine or some type of stress test to kind of risk stratify this person. And we'll go over what I think is the better answers towards the end after we've gone over the AHA-ACC guidelines. So here's a 65-year-old man who needs a prostatectomy. He has no history of angina, doesn't do a whole lot of physical activity other than normal walking. Again, he has risk factors, hypertension, hyperlipidemia, he smokes. His internist decides to get a stress test as sort of a preoperative risk assessment tool, and he walks for 12 minutes on a Bruce protocol. Now that's 4 stages on a Bruce. So you're actually at a pretty good incline and you're walking pretty fast. And he does this without any chest pain, but he has 1 millimeter of ST depressions in leads V5 and V6, and the test is called positive for ischemia. What would you recommend? Proceed with plans for surgery, get a more sensitive test such as a dobutamine echo, cancel the surgery, refer to cardiology, or refer for coronary angiography and think about possible revascularization prior to prostate surgery. Just hands, how many of you would just proceed to surgery? A few? How many would ask for a cardiology consult at this point? Okay, reasonable, a positive stress test. Okay, so we'll touch on these topics towards the end. Now, I think that as I've thought about this and seeing patients, I think what drives a lot of what we do going into the surgical period are based on the following 3 assumptions. Okay, and these 3 assumptions are, one, that our clinical assessment, history, physical, the data that we get from labs, etc., is just not good enough in predicting who's at risk. And this obviously leads to assumption number 2, is that we need more testing. So we're going to use non-invasive tests, and there's an assumption that these tests are actually pretty good at predicting who is going to have the intraoperative or perioperative cardiac event. And so that leads to assumption number 3, which is that we need these stress tests to identify the high-risk patient so that we can revascularize people before they go off for their non-cardiac surgery in order to lower their risks. And I think all of these are assumptions that aren't necessarily supported by what we now know from the data, and I'd like to go through all that. So assumption number 1 is that our clinical assessment, history and physical, is simply not good at predicting who is going to have the perioperative cardiac events. Well, when we talk about the risk of cardiac complications, we should really ask 2 questions. What type of surgery are we dealing with, and what type of patient are we dealing with? And we ask about type of patient, we should really be asking what are their clinical risk factors, what type of functional capacity do they have, because no matter what you do, the better functional capacity a person has, the lower their risk is, and that's just been shown over and over and over again. And then are there any active cardiac conditions right now that we should be aware of before going off for non-cardiac surgery? Well, here's a list of different types of surgeries. I think a lot of you are familiar with this. The high-risk surgery with respect to cardiac complications are usually either the emergent surgeries, particularly in the elderly, the aortic and major vascular surgeries, and the peripheral vascular surgery. These are surgeries associated with a greater than 5% perioperative cardiac risk. The intermediate risk surgeries, carotid endarterectomies, head and neck surgery, orthopedic surgeries, prostate surgery, anywhere from 1 to 5%, and then low cardiac risk, endoscopic, superficial procedures, cataracts, breast surgery, etc. So we can get a pretty good idea of surgical risk just by knowing what the surgery is. Now, what about the patient? Well, let's ask the first question, what type of functional capacity do they have? And really one of the questions you can ask with simple questions and a simple history is, can the patient perform more than 4 METs? And this is an idea of what 4 METs would be: climbing a flight of stairs, walking up a hill, walk on a level ground at 4 miles an hour, run a short distance, do heavy housework, participate in moderate recreational activities. I mean, when a person says to me, oh, I walk 5 miles a day, I rarely am worried about that person in the OR, or I rarely think that I'm going to be able to do something to reduce that patient's risk. So their functional capacity is very important. Can they do, at a bare minimum, some of the things that you see here on this list? And this is a good example of when a person feels that they can do a good amount of physical activity, they're at lower risk compared to when they tell you that they cannot. So you can see here that if a person described their exercise tolerance as poor, they had twice the risk in terms of cardiac complications, and total serious complications doubled compared to patients who described their functional capacity as being good. Now, we need to be able to also then look at the patient and say, are there active cardiac conditions going on right now? And what are those active cardiac conditions? Unstable coronary syndromes. I would not take somebody for an elective operation if they were telling me that every night while watching the news they have chest pressure that lasts 20 minutes. You know, that is an active cardiac condition that you would want to address. Are they in acute decompensated heart failure? Do they have arrhythmias, supraventricular, bradyarrhythmias? Are we seeing Mobitz 2 on their EKG? Are they dropping beats? So these are things that should be addressed before we go off for surgery. Is there severe valvular disease? And if somebody has critical aortic stenosis, we would want to address that before going off for non-cardiac surgery. So these are the active cardiac conditions that we need to make sure that we're aware of. Now, most people don't have an active cardiac condition going into surgery, and so we then need to ask ourselves, are there other clinical risk factors that increase a person's risk? And these are some of the risk indices that have been developed over the years, starting with Goldman's in the 70s, then Detsky's in the 80s, and the most recent one in the late 90s is the Revised Cardiac Risk Index by Lee et al. And this is the one that's been probably validated best with the largest number of patients, and I think the easiest one to remember. So with the Lee Revised Cardiac Risk Index, there are only 6 points to remember, and here they are. You get 1 point for each yes to this list. Is the patient having high-risk surgery, so aortic or peripheral vascular? Does the patient have a history of ischemic heart disease? Do they have a history of congestive heart failure? Have they had a history of TIA or stroke? Were they on insulin going into surgery? So not just having diabetes, but being on insulin. And then finally, do they have a preoperative creatinine greater than 2? It's not hard to remember these 6 things, and then to say, how many of these do my patients have? And as you can see, that with each additional point, your risk goes up. So if you have 0 or 1 points with the Revised Cardiac Risk Index, your perioperative risk is pretty low. It's going to be hard to reduce a person's risk with stress testing and interventions when it starts at less than 1%. All right, when their points are 2, you can see it jumps up to 6.5%, and with 3 or more risk factors, it's 11% or greater. So with a simple history and physical, and getting some background information on a patient and asking about their functional capacity, we should be able to look at somebody and say, this is a high-risk patient, this is a low-risk patient, this is an intermediate-risk patient. And I think you're going to see as I show slides over the next few minutes that when these points add up or when the points are low, we have a pretty good sense of who's going to do well or poorly in the short term as well as the long term. So assumption number 1 is that our clinical assessment by history and physical isn't good enough, I think is probably incorrect. But that often leads to assumption number 2, which that we need non-invasive tests to predict who is going to do poorly because these tests are actually good at predicting that. Well, actually, if you look at lots of different non-invasive tests, Holter, treadmill tests, perfusion studies, dobutamine stress echo, the sensitivity and specificity of these tests are not particularly good. And what we really want is we want to know what the predictive value of these tests are. So here's a good example of a bunch of high-risk surgeries, vascular, aorta, some mixed, where they did look at the value of nuclear perfusion imaging before the test. Now, if you look at the far right-hand column, you can see that the negative predictive value is actually quite good. So these tests, these stress tests, are actually very good at telling you, if it's negative, that this person is unlikely to have a perioperative cardiac event. But look at the positive predictive value. So incredibly low. So what that tells us is that these tests are not very good at predicting who is going to have the intraoperative or perioperative MI. So a positive stress test is not a very good predictor of who's going to do poorly. But you can imagine what a positive stress test leads to in terms of anxiety, further testing, perhaps a huge cost and other complications. What about dobutamine stress echo? Is that any better? Well, again, the far right-hand column, the negative predictive value of dobutamine stress echo is quite good. If it's a negative test, that patient's unlikely to have an infarct in the OR. But again, the positive predictive value, incredibly poor. So a positive dobutamine echo, to me, doesn't tell me that that person's going to go off and have an infarct, yet again, the anxiety it creates is tremendous. Now, this idea of should we do stress testing to kind of get a sense of who's at higher or lower risk has been studied prospectively, and here's one of the studies. There have been several. Here's one called Decrease 2. It was done by Polderman and his group. And what they wanted to do is look at intermediate risk patients who were going for high risk surgery. And they wanted to randomize people to either get stress testing or no stress testing, and then see how people did, both short and long term. Now, here is the study design. You can see that if you had 0 risk factors, you were not in the study. If you had 3 or more, you were not in the study. Those were considered low and high risk, and they were targeting intermediate risk people. So 1 or 2 clinical risk factors. And they randomized these patients to either get stress testing under the no column, so 384 did not get stress testing, and 386 did get stress testing. And they managed these patients clinically. So some patients who got stress testing had a negative stress test, some had a very mildly positive one, and they were treated medically. Some had a very positive stress test, and some of these patients were revascularized. And then they compared how they did. Well, the first thing that jumped out in terms of differences was how long it took to then get to your non-cardiac surgery. We just heard Dr. Feldman say that delaying surgery isn't good. Well, this delayed surgery about 3 weeks if you ended up going for a stress test. And you can imagine why. A positive test that leads to the next step, that leads to the next step. So certainly it delays surgery, we know that, but does it help in terms of outcomes? Well, again, we're looking at the 1 or 2 risk factor people, and you can see that these patients did have a higher risk of cardiovascular death or myocardial infarction compared to the people with no risk factors. So we would know that just from doing the revised cardiac risk index and adding up the points. So again, that seemed to bear out. But what about whether you got a stress test or not? Well, it turns out that the people who were stress tested did no better than the people who were not. And not only was that true in the immediate perioperative period, but look at this in terms of long-term cardiovascular death or myocardial infarction. You can see that on the right side of the screen that it didn't matter not only in the perioperative period, but at year 1, 2, or 3, people didn't do any better or worse if they underwent stress testing. And there have been several studies that have given the same take-home message. So it is a little hard to read study after study like this and to say we should be doing stress tests on everybody because it will lead to a strategy that lowers risk. We just haven't been able to prove that to ourselves. And this is why the ACC and AHA do not emphasize in a way that you would consider strong to do stress tests before every operation. Here are their AHA, ACC recommendations when it comes to stress testing. Notice you will not see a single class 1 indication here. All right, the best and the strongest indication is a class 2A in red, but most of the patients here, no stress test is recommended. So if you're a low-risk surgery, doesn't matter whether you have good exercise capacity or poor, they don't recommend a stress test. If you have intermediate risk surgery and your functional capacity is good, no stress test. If it's not good, then it's a class 2B recommendation. You could consider doing it if you think it's really going to change your management. The only group that gets a class 2A recommendation are what we would consider the highest risk patients based on their type of surgery, the fact that they have poor functional capacity, and they have lots of clinical risk factors. That's the only group that gets a class 2A, and once again, they couch that in the expression, if you think it's going to change your clinical management. So the emphasis on stress testing, which I think there is a great emphasis on, and I think we spend billions in this country every year doing preoperative stress testing, the data just isn't there that we're reducing risk with that strategy. Now, when we do these stress tests, I don't see, as a cardiologist, I don't see any reason why we would do a stress test if we're not prepared to act on the results of that stress test. So obviously when we do a stress test, we're saying we're trying to figure out who's at high risk with respect to anatomy, and we're going to go in and intervene on that anatomy. So here's assumption number 3. Revascularizing patients will decrease the risk of perioperative cardiac events. That totally makes sense. The question is that what the data shows? Well, there have been 2 studies now looking at if we revascularize patients, does it lead to a reduced outcome, a reduced risk perioperatively? The first one was called the CARP trial, C-A-R-P, which you can see here where they looked at VA patients who were going for vascular surgery, so high-risk surgery. They enrolled over 500 patients. These were people who had significant coronary disease. They excluded people with very low ejection fraction, aortic stenosis, left main disease. And then they randomized them to revascularization, either with stents or with bypass surgery, and versus medical therapy. And then they waited and then did the vascular surgery after they recovered from their coronary revascularization. And here again is the design of the trial. 258 of the patients were revascularized, either with stents or with bypass, and 252 were not revascularized. So again, what did we learn? The people that were revascularized waited weeks longer for their vascular surgery. That makes sense. They had to recover from either bypass or from PCI. But look at the rest of the table there. How did they compare in terms of death within 30 days? No difference. MI, no difference. Stroke, no difference. Time in the ICU, no difference. Time in the hospital, no difference. And there are certain graphs that stick in my mind as I've gone through my career, and this is one of them. Long-term survival, no difference. And this is totally non-intuitive, right? You took people with significant coronary disease, some of them got bypassed, some of them got stents, and then not only didn't they do any better in the immediate perioperative period, there was no difference in how they did over the next several years. So it's kind of hard to make the argument we need to stress test people so that we can then do a heart catheterization, figure out their anatomy, revascularize them so that we can then lower their risk when we have data like this. It's counterintuitive perhaps, but here's the data. There's another study, Decrease 5, by the Polderman group again. They did something similar, do high-risk patients, so greater than 3 risk factors, and extensive ischemia by stress testing. All right, so these were floridly positive stress tests who are going for high-risk surgery, meaning vascular surgery, Do they benefit from prophylactic coronary revascularization? Same question as the other trial. And here's what they did. This was a smaller study, but they randomized people to either get revascularized or not revascularized. And then they went off and had their vascular surgery. And then they did some follow-up. Well, looking at events in the first 30 days, if you look at all-cause mortality and non-fatal MI, they had a lot of mortality and MIs, as you would expect in this very high-risk patient population, but there was no difference between the group that was revascularized and the group that wasn't. And what about events up to 1 year? Again, no difference if you were revascularized. So again, we have a couple of studies, we don't have tons of studies, but we have a couple. And again, the take-home message seems to be that revascularizing people before we go for non-cardiac surgery does not seem to lead to a strategy that lowers their risk. So our three common assumptions: that our clinical assessment is not good enough, I would say is the wrong assumption. A second assumption, that non-invasive tests are good at finding out who is going to be at the highest risk, is also not a good assumption. And the third assumption, that we will lower risk by revascularizing people, is also, I think, a wrong assumption based on the data that's now available. So there's something else, though, that I want you guys to be thinking about as we think about revascularization. Because I hear a lot from surgical teams and anesthesiologists that, listen, they had a positive stress test, we should do that cath. If there's something there, we should fix it before we proceed to surgery. I think we also have to think about the next sort of subtopic, which is, in the modern era, that people are getting stents as part of their revascularization strategy, and what that means in terms of perioperative risk. The type of stent that's being used most commonly now is the drug-eluting stent. When you put in a drug-eluting stent, that stent, because it's drug-coated, will inhibit the endothelialization of that stent, which means that stent is at high risk for clotting actually it turns out to be in the first several months, if not first year, after you put that stent in. So these patients, after they get drug-eluting stents, are highly dependent on antiplatelet therapy, and in particularly a dual antiplatelet therapy. All right, so patients need to be on a lot of antiplatelet therapy after we put stents in. And a good number of stents that thrombose, the majority of stents that thrombose, that clot off acutely, are due to the withdrawal of antiplatelet therapy. And you think about the perfect storm for stent thrombosis, it would be someone who gets a drug-eluting stent and in a short time after that goes to an operation where there's increased platelet reactivity to begin with, and prior to that we withdraw dual antiplatelet therapy or even take away one of the antiplatelet agents. This is the perfect storm for stent thrombosis. So if a patient has had a cath and there's a 70% smooth lesion in the right coronary artery, I have had anesthesiologists say to me, I am not doing this surgery, we're not putting this patient to sleep unless you fix that lesion. When you go in and you take a balloon and you crack open that smooth 70% plaque and put in a metal stent and then put them on dual antiplatelet therapy and then say, all right, let's do the surgery in 3 weeks, and then take that dual antiplatelet therapy away, you have created a much more volatile environment than there was when you had a smooth 70% lesion beforehand. So we have to be thinking about this, not just in terms of does revascularization improve outcomes, and I would argue that the data has not shown that, but are we increasing risk by intervening? And I think you could make an argument that we are, that our strategies are leading to increased risk when we revascularize, we put people on antiplatelet therapy, and then we remove that antiplatelet therapy for surgery. And this study, just to mention it briefly, demonstrates exactly that. Late surgery means that people got stents and then they waited quite a long time before they did the surgery. And you can see that they had very few major adverse cardiac events. Early surgery are people who had stents put in, and then they had surgery in a relatively short time after that. You can see that the risk of major adverse cardiac events went up. But if you break down who actually had those events, it were the people who had the early surgery where they stopped the antiplatelet therapy. You can see there that up to 30% of the patients who had surgery early and had their antiplatelets removed were actually had the major adverse cardiac event. So we really should be trying to avoid that. And if we know somebody's going to need non-cardiac surgery, we should be thinking about what type of stent to put in. Not all stents are drug-coated. Some are bare metal. The bare metal stents are less likely to thrombose when you remove antiplatelet therapy in the acute setting. So if you know surgery is coming down the pike and you're planning for that, a bare metal stent is probably the way to go. You should wait 30 to 45 days before trying to withdraw any kind of antiplatelet therapy. If you put in a drug-eluting stent, the recommendation is to wait at least 12 months before removing antiplatelet therapy. Now, I should mention, though, that even with bare metal stents, the recommendation is still 12 months of dual antiplatelet therapy, but your risk of thrombosis is less with the bare metal stents. All of this should be in our thought process as we move towards revascularization. Now, kind of sounds bleak. I've said we're not very good at lowering risk in anything that we do. What about medications? Well, it turns out that medications can be effective in lowering risk, and that includes antiplatelet therapy, beta blockers, and statins. We want to avoid overlap of discussions in our talk, so Dr. Faraday is going to talk more about the specific medications and their interventions and how that affects risk in the perioperative period. So if we take a look at this algorithm up here, this is the ACC-AHA algorithm for thinking about stress testing, and I think it's worth going through, and I think it's worth looking at next time you have a patient who you're thinking about sending to the OR, because these are the current guidelines based on the data that's now available. So if they need emergent surgery, non-cardiac surgery, you go. You don't worry about other things, you go to the OR. I think that one's fairly self-explanatory. If it's not emergent surgery, we move on to point number 2. You ask yourself, are there active cardiac conditions? Does the patient have heart failure? Does he have unstable angina? Does he have ventricular arrhythmias? Is he having atrial arrhythmias? You address those issues before going for non-cardiac surgery. Now, what if there are no active cardiac issues? Bullet point number 3. Is it low-risk surgery? If the answer is yes, you proceed. That's where we are right now. If surgery is low risk, we don't need stress testing, we don't need any kind of non-invasive workup, you can proceed to surgery. Now again, all cases need to be looked at individually. These are sort of overall guidelines. Of course, there'll be certain exceptions to this. But low-risk surgery patients can proceed. If it's not low-risk surgery, so intermediate or high risk, the next question is, what's their functional capacity? So if I got a patient that jogs 5 miles a day, I don't care where they are on this algorithm, you can go to surgery. Okay? You're not going to help that patient a whole lot by sending them for a treadmill test beforehand. All right, so if their functional capacity is good, if it's an intermediate or high-risk test, you can still go to surgery. Now, in many patients, we don't know what the functional capacity is, either because they never exercise or because we're meeting them for the first time in a hospital bed. So if you don't know what the functional capacity is, and it's an intermediate or high-risk test, that's when we start asking about risk factors. All right? If there are 0 risk factors based on the ones that we've talked about, you can proceed to surgery. If they have 1 or 2 risk factors, you can probably proceed to surgery without stress testing. Maybe some will get a beta blocker. Dr. Faraday will talk more about that. And only the patients that are going for high-risk surgery, this is on the far left, that have 3 or more risk factors, going for the highest, vascular surgery, high-risk surgery, would you think about a stress test? And frankly, even for those patients, the recommendation is if you think it's going to change your management, which is a big if. So this is now the algorithm that we should be using, I think, based on the data that we now have in thinking about how to manage people preoperatively. So if we go back to those 2 questions that I asked you earlier, here's this 68-year-old man. He's going for hernia surgery. If you actually add up his revised cardiac risk index, it comes to 0. All right, so he has 0 of the things on that revised cardiac risk index list. This is someone with, maybe you could argue, going for intermediate risk surgery, where we don't know about his functional capacity because he doesn't do very much, but who has 0 risk. If you went down, or 0 risk factors, if you went down that algorithm, the recommendation would be to go to surgery. A dobutamine echo, a persantine is not going to help you very much. If some of you thought about putting him on a beta blocker, that's not wrong, but there are ways to start beta blockers preoperatively that Dr. Faraday will talk about. We should not be blasting away with beta blockers in the 24 hours prior to going to the OR, but certainly it wouldn't be wrong to start a beta blocker in the right way on some of these patients. What about this guy? 65-year-old man. He's going for prostatectomy, and he's got pretty good functional capacity based on that treadmill test. He went for 12 minutes on a Bruce protocol. Any of you that's ever done a Bruce protocol stress test, you know that by 12 minutes, it's not a gentle walk anymore. You're huffing it up a hill. So when a patient gets to 12 minutes on a Bruce protocol and doesn't have any symptoms, you know, the EKG is important, but to be honest, the most important thing in my mind as a cardiologist is the functional capacity. So yes, he's got 1 millimeter of ST depression. Maybe it's real because he's got coronary disease, or maybe it's a false positive. Don't really know, but I think we can be pretty reassured about this. And what we do know is that people that have positive stress tests, it's not very predictive of how they're going to do in the perioperative period. So here you have a patient going for intermediate risk surgery who has got tremendously good functional capacity. My recommendation would be to proceed with surgery. It would not be wrong to send him to a cardiologist, but that's what I would say, proceed to surgery, and these are the reasons why. So in conclusion, clinical risk factors, I think, are good at predicting who is going to have the perioperative cardiac events. Non-invasive imaging can actually add to that information. I'm not saying that it can't tell you things, but they're not very good at predicting who is going to have the perioperative infarct. There is no evidence right now that these non-invasive tests lead to a strategy that reduce risk in the perioperative period. Another point, prophylactic coronary artery revascularization before non-cardiac surgery does not improve short or long-term outcomes. That is just the fact right now based on the data that we have. And the indication to revascularize somebody preoperatively should be the same indication as always. They have left main disease, they're having unstable angina, some of the same things that we use when someone's not going for surgery. And then finally, when we put stents in, premature termination of dual antiplatelet therapy is probably the major thing that we can do as doctors to increase the risk of these patients. We should think very carefully about what we're doing in terms of revascularization.